surprise too many of you. You don't have to record it if you don't want.
Okay.
But I work at Dayton Children's. I've been there for almost 22 years now as a respiratory therapist. I've been on the transport team there for about 20 years, a little over 20 years now. So I've got a lot of the interfacility type transport life, under my belt. But 2 years ago, we added on an ALS crew. So with that, as being the manager of the transport department and comm center, I felt like it was in my crew's best interest if I became a basic and then eventually a paramedic. So I know what you guys, go through. I know what your knowledge base is, and I can advocate for them better. So with that, I'm currently, just last year, got my EMT basic. I start in the fall to get my paramedic. So you never know, I may be seeing you guys around at some point or another as a student. But if anybody ever has any PEDS questions, you have issues with comm center, you have any other questions, feel free to contact me at the hospital. I'm more than happy to talk to anybody and try and work out anything. So I'm not doing a PowerPoint today. We're just going to do a short little kind of reminder of some things and maybe kind of some question and answer if anybody has any questions. PowerPoint's boring. We don't want to do any of that. So first I want to kind of go over why the pediatric airway is a little bit different than adults. I know you guys are, most everybody's used to the adults because there's a lot more of them. Kids you don't tend to see a whole lot of unless it's an emergency type situation. With especially babies, their airways are made up a little bit differently. They have a narrowing. The cricoid is actually the narrowest part of the airway. And as they get older, it kind of widens out, which is why the cric rule comes into effect at 8 or 12, depending on which department you're talking to. But for you guys, it'll be 8. Also, the babies, when they're born, their ribs are more made of cartilage. They're not stiff like in adults. It's not the bony structures. So adults, if they're having low oxygen, they're having trouble breathing, anything like that, they can take a deeper breath a lot easier than babies can and children. So they can increase that minute volume a lot easier. So they don't necessarily have to breathe faster, they just have to take deeper breaths, which then helps keep the lungs open. Well, with the babies and the cartilage in the ribs, they start more retracting. That's why you see all the retractions, and you see them breathe fast, is because they can't take those deep breaths. They have to increase the respiratory rate in order to get that increased minute volume to be able to blow off the CO2 and such. With that also comes the airways in the lungs are a lot smaller. For obvious reasons, they're smaller, so their airways are going to be smaller. With that increased respiratory rate, a lot of times they have a harder time opening those airways up. So you'll get a lot of atelectasis. You may even get some hyperinflation, like some air trapping in the lungs. So that's kind of the reason you'll see a lot of the kids are a little bit different than the adults. And it's good to kind of think along those lines as you're taking care of these kids. So you know why they're doing these things. If their oxygen level's low, they're going to increase their respiratory rate. The other thing is, not so much right now, but more in the winter time. I know you guys have seen those snotty kids come in. You get called, they're breathing fast. They get snot running all down their face. That's like the wintertime thing. Babies are what we call obligate nose breathers. They don't know how to breathe through their mouths. So when their nose gets all clogged up with all the snot and mucus and everything, it's just like sticking something in their throat and obstructing their airway. They can't breathe. So if you suction out their nose, it is amazing the difference that it makes in these kids. If you can just get that airway cleaned out, get the snot out, they breathe a lot easier. So that's something you think about in the wintertime. If you see these kids, go ahead and try and suction their nose, see if their breathing gets better. The other thing with kids, especially infants and toddlers, a lot of babies have reflux. They may not necessarily be diagnosed as it, but if you get that kid that comes in and mom's saying, oh, he's just spitting up all the time, kind of think in the back of your head, he's probably got a little bit of reflux. And all that acid, if anybody's had heartburn, you know, you get that kind of irritated feeling in your throat and everything. It's the same thing with the babies. The issue with all that is they tend to aspirate with that, and with their airway made thinner at that cricoid, when they start getting that irritation in their throat, they can get swelling in there and have some issues. So reflux could be a lot more of an issue in a baby than it could be in an adult. So it's not something everybody thinks of, but you know, it can cause some issues with that. The other things you see a lot of times with kids, and unfortunately we've been seeing it even in babies and toddlers, families, we see a lot of drug use in the area, the Dayton region right now, and have been for a while. I'm sure you guys have gone through all the whole Narcan stuff, but we've actually had 9-month-old, and we've even had 2-year-old where we've had to Narcan because the kids have gotten into the parents' drug stash. So I hate to say it, you know, you would think it'd be more the older group, but you could see it in kids also. So keep that in the back of mind if you're coming into a situation where kind of a little iffy about the area, kind of a little iffy about, you know, the family or what you're seeing when you walk into the house. Just kind of keep in the back of your mind that that's a possibility. It's not, like I said, not something you normally think of with kids that age group, but we've been seeing it. So. The other thing is seizures. Obviously, we all know, everybody's seen the febrile seizures, and you know, we get a lot of kids around the area that have epilepsy, that sort of thing. So, you know, just make sure their airway, they're able to support their airway after they have these seizures, because sometimes when they're postictal, you may kind of have to help them along a little bit. Most of the time they're fine. You don't have to worry about it, but there are those times where they will close up their airway because they can't keep the tongue up off the back of their throat. Signs of impending respiratory failure. The difference with kids versus adults is kids will just go, 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 and then they're done. They don't have that steady decline that you see in the adults. You know, the adults, you can pretty much tell that they're going towards that respiratory failure, and you've got time to do some things to kind of fix it before they get there. One of the late signs of respiratory failure with kids is loss of consciousness. You know, you can get an adult that will lose consciousness, and you still got, you know, you've got these other factors that you can do to kind of keep them going. Once a kid loses consciousness, usually they're down very, very quickly right after that. They can keep their blood pressure steady up until that point also. So you can't rely on the low blood pressure if the kid's awake and they're, you know, once they start slowing their respiratory rate down and looking like they're going to go unconscious, you're in a world of trouble at that point. Want to look at cap refill. Cap refill in kids is a really good pre-indicator before that blood pressure drops. Cap refill less than 2, or greater than 2, sorry. You want to maybe think about a fluid bolus, because sometimes with kids, it's the respiratory status that's usually the first to go, and then the next one is give them a little bit of fluid. A lot of times it'll keep them going, keep them out of that respiratory failure stage. They can also hold their sats for a long time. Even if they're looking great, if their cap refills, extend it out, they may be getting close, like I said, getting close to that respiratory failure type thing, so. If your respiratory rate in a child under the age of 1 drops less than 20, that's a big concern too. Like I said, they'll usually breathe. They usually breathe fast, really tachypnic, but once you start to see their respiratory rate dropping, if you haven't done anything to help facilitate that to drop, then you need to worry about whether they're going to lose consciousness or have some issues. So with blood pressures, just a quick reminder for pediatrics, blood pressure is 70 plus the age times 2. So if you have a 2-year-old, you want your systolic blood pressure to be 74. That's just a little reminder. I'm sure everybody knows that, but I was asked by Bobby to go with you guys. In the protocols and also with children's, we prefer, because of the airway differences that have kind of gone over, and face it, not a lot of people do intubate for pediatrics just because there's not that vast number of them. So what we prefer, and what the protocols emphasizes, is putting in either an LMA or a King airway. Dayton Children's, we actually prefer the King airway. We think it's a little more secure. And we've had lots of times where the LMAs have been in, and when we move them over to the bed, they get dislodged because it's just a mask that goes down in there basically, so it's very easy to dislodge. The King airways, if the kid is unstable, if they're in and it's working, we can actually leave that airway in for up to 8 hours prior to us changing the tube out. So that gives us time at Children's to stabilize them out before we have to intubate and change the airway out. So, we like to see the King airway come in, but either one is totally fine. As long as you get an airway and you're ventilating, we're quite happy with that. And then, like I said, a lot of times you can just ventilate the kids and you'll get your heart rate back, because with kids, it's either usually trauma or respiratory is the two main things that we see as to why a kid either codes or goes into failure. With CPR, we want to stress to make sure we're doing very good CPR, good chest recoil, deep enough, and continual. If you stop your compressions for the 10-second check for a pulse, it takes 1.5 minutes of continuous CPR to get back to full circulation of the body. So it is really, really important to be doing that continual CPR and not have that many breaks and have a good CPR. Same with an adult as with kids. You just want that continual CPR. So the other thing they wanted me to go over is the 3-way stopcock. I'm sure you guys have all seen this at some point or another. But this is easy for, look over here. This would be your syringe of, say, your epi. With especially the babies, they need such small doses. It's really hard to give a dose of epi off of the regular syringe. And you guys don't have time to be pulling syringes out and trying to draw them up out of the syringe to be able to get the right dosages. So this is a nice, easy way to pull up your smaller dosages, like your 0.2, 0.3. Put your epi syringe over here, your 3-way stopcock, and then your 1 cc syringe. Turn your stopcock off this way, so that way these two sides are open. And when you draw up your fluid here, it'll actually automatically pull it from the syringe. So that way you can either take it right off of there and give it. You still have all your fluid in here, you just put another syringe right on top of here, and you can draw it up more if you need a second dose. So it's a nice, easy way a lot faster than trying to draw out the syringe and draw it out of the bigger syringe. What I was saying to the other guys yesterday is you can also have this hooked up to the patient's IV on this side. You just, once you draw up your syringe here, you just have to turn your stopcock off to this syringe and you can push it right to the patient. The trick with that is we do have such small dosages in here, and this goes for whether you pull the syringe off or run it through here to the patient. You need to flush, because they are such small doses, you need to flush that medicine to the patient. Otherwise, it's just going to sit in the tubing and it's not actually going to get to your patient. So, kind of got to think of that as such small doses. You got to make sure you're flushing it to the patient. So, does anybody have any questions about any of that? Any comments? No?
Is there a preferred airway with like swollen airway where there's allergic reaction or epiglottitis where you've got limited time? I'm sure
Whatever you can get in at that point.
So going straight to a regular tube on something on an extreme case like that would be more acceptable.
Yeah, whatever you can get in at that point, save the airway.
Just for everybody in the group, we're not replacing LMAs anymore, so if you do have LMAs, once they expire, discard them. You should all have King Airways in your bags and in your stations. If you don't, let me or Rahi know, but don't request LMAs. We're not replacing them anymore. They'll all be replaced with King Airways for all the sizes.
So that's what we stock at Children's for you guys, is the King Airways. So I think Dayton Fire is the only ones that are sticking with the LMAs. Everybody else in the region are all moving to Kings. Anybody have any situations they've run across? Have any questions about anything that?
I do have a question on drownings.
Yes.
So we had a request to purchase some PEEPs, some PEEP valves.
Mm-hmm.
What's your opinion on those as related to drownings or any arrest or respiratory?
It'll help you.
Okay.
We use PEEP on all of our bags at Children's. With the drownings, what it'll do is if you have that PEEP set, it'll help push the fluid out of the lungs so you can ventilate better.
Okay. Do you guys use the adjustable?
Mm-hmm.
And is there a standard setting or is it just?
We usually start with 5.